So I'm going to show you what CODEX actually is and give you a flavor of it as if you were a clinician or a patient. But before I do that, I want to emphasize how impactful this is. And as a consultant, we get to see a lot of really cool, really innovative projects. And I have to say, I can count on one hand the number of projects that have this kind of impact. And really, there's two major fields that CODEX impacts. The first is actual clinical care through an app called Patients Like Mine. This is kind of becoming an established app. It was first published in the New England Journal like in 2011, but it's really been rate limited. And what Dr. Markovich and Lisa did was kind of break through that with a really important innovation. We're going to take you through that in a minute. But what Patients Like Mine app means to a clinician is exactly as Dr. Markovich said, when the evidence basis runs out, he's not left with just hunches and guesses, right? He can look at his own experience, Lisa's experience, the rest of the Mayo Clinic's experience, and someday if this is connected to other institutions, beyond. So we have our clinical trials-based evidence, and we'll have our real-world evidence through Patients Like Mine applications. So it'll be massively impactful in the clinic. And similarly to patients, imagine if you were one of these patients and you asked Dr. Markovic, what's been your experience? And he turned the monitor around and said, well, here it is. We've seen 111 patients just like you. This is how we treated them, and this is how they did. Imagine what that means for patients. And finally, for the payer community, we've already taken this concept out and talked to the payers. They can't use this real-world evidence to deny a treatment, but they can use it to educate the physicians and have all of their physicians practicing at the level of Lisa and Dr. Markovich. So just on that clinical Patients Like Mine side, hugely impactful. But there's a whole other thing. We're not going to talk in too much detail about this today, but it's the real-world evidence aspect of this. And I call CODEX essentially a real-world evidence accelerator. So the researchers, clinical researchers, basic scientist researchers, they can use this evidence from the clinic for hypothesis generation, target development, all sorts of great things in the clinic. The pharma companies can use it in myriad ways. We're in a number of discussions with them. They literally can use CODEX from the very proximal step of target identification all the way through how should they convince payers of the value of their medications, for example. And then finally, the regulatory bodies, they've been so focused on the clinical trials-based evidence basis, they're moving to incorporate this real-world evidence as fast as they can. So CODEX just has this massive, massive impact. And I don't know if Dr. Markovich set out to have all these impacts or if it was just basically a pain point that he was having in the clinic, but maybe we can ask him in a minute. So this is CODEX in action. So imagine that's a younger version of Dr. Markovich there. Seeing a patient, he had blonde hair when he was in his 20s. Seeing a patient, and this patient has some very unique characteristics. And the challenge is, how do you extrapolate that individual patient to what's in the clinical trials published literature? That is an art in and of itself. And so the Patient Like Mine application allows him to pick off a few of the key characteristics that define this patient, and then ask, what has been our experience? How have these patients been treated? So here's the rate-limiting thing that Dr. Markovich and Lisa broke through, and the real sort of secret sauce of this case study is, in most electronic medical records, in most disease conditions, it's a very arduous process to assess, did this patient respond to a therapy? I mean, in diabetes, we have like hemoglobin A1C, but in a lot of other conditions like oncology, it's really hard. And if you get 2 or 3 oncologists in the room, you'll probably have 5 opinions about did they progress or did they not progress. And so Dr. Markovich's real insight here was, well, in today's day and age, with the new medicines, targeted therapies that we have, if the patient stays on the medication, it means it's working. The tumors, it's either regressing or it's not progressing the way they expected. The side effects are manageable. So the longer the patient stays on the medication, it reflects the treatment success. And we can use that as a proxy measure to scan through every patient's electronic medical record and get a sense of how they're doing. Now, this isn't going to apply to all conditions. Let's say you had pneumonia. and you went on an antibiotic, you wouldn't expect to be on that antibiotic for the rest of your life. But many conditions, even outside of oncology, multiple sclerosis, rheumatoid arthritis, these patients are on medications for a really, really long time. And so if you have more patients like Steve here that has a long time to treatment change, and fewer patients like Mary, who has a short time to treatment change, you'll see that nice, beautiful Kaplan-Meier curve. The blue curve at the top is good. The red curve at the bottom is bad. You want to be in that top group. And so this was kind of the essential insight. And I think the thing we want to talk about, how did the innovation process lead to this insight? So once we had this insight, it was really important, being good scientists, we had to say, look, it looks right, but can we actually validate this? When we compare it to the evidence basis that we have in the medical literature, does this hold water, this time to treatment change insight? And I'm going to let the good doctors just explain what we're seeing here on this.
So you guys, so basically when we first started to do this, and the question was, what do we tackle first? What do we tackle first so we will understand that the algorithm that we developed would actually be meaningful? So what we decided to do, how about we test the known knowns? How about we test whether or not patients that we were treating with our clinical practice that were very similar to patients that were treated on experimental clinical trials with the same drugs, would our performance of our patients, would that reflect what was already known in a highly regulated, highly structured, randomized phase 3 clinical trial? So ask the known known. And here is what we got. On the left is a New England Journal lead article presenting the effects of these two agents in patients with advanced melanoma. On the right is that same patient population analyzed by us. Merry Christmas to me, happily ever after, mic down, I'm out of here.
So the next step, obviously, is to take this outside of metastatic melanoma to other oncologic conditions, and then outside of that into other treatment areas where this time to treatment change metric will apply. So, okay, so that was kind of the core innovation, and now I want to just make a couple comments about why this happened. So the book that Joe was referring to, the Medici Effect, to spoil the plot of the book, it's a great book. Dr. Markovich turned us on to it. The idea is, why did the Renaissance happen? What was the role of the Medici family in bringing artisans and scientists and clergy and merchants and travelers and bring them all into one place, and then kind of watch the magic happen and watch the Renaissance happen? And I mean, that happened in spades on this project, and I think it's kind of the premier take-home lesson from this was we needed brilliant scientists and clinicians to come up with this idea. We needed people that had the teams in place. We had, I view our role as consultants was really just a force multiplier for Joe and Dr. Markovich. And then we had to have Andy to kind of fund the thing and have the prescience to make it all go. So I'm going to leave you with one example of forming these teams. So when we do analytics projects and artificial intelligence projects, what we're starting to do a lot of now, we create these pods. And so if you're working on an innovation project and you have a big team, I mean, I always say, danger, Will Robinson. So we have essentially a pod of 4 people. And so probably the critical element there is that one at the top, sort of the domain IT, we call them bilinguals. So someone that can sit in Dr. Markovich and Lisa's office, look at them as they're seeing patients and putting these in the electronic medical record, and then walk down the hall and talk to Joe and talk to IT and say, these data elements and these databases, these are the kinds of things that Dr. Markovich is looking at. So, and it can't be 2 people, it has to be one mind. Right? It has to be someone that's if it's a clinical domain clinician, if it's supply chain, a supply chain person, you really have to have that translator, right? And then we have a data expert, and I'm going to emphasize the word health. So I have lots of experience bringing people from manufacturing and retail and bringing them over to healthcare, and there's minimum 9-month learning curve for them to be really functional. So we need to have those healthcare data experts. Obviously, we need a rich analytics person. In this case, we had biostatisticians sort of on call to come in and provide that perspective. And then you need a product manager, product strategist person to kind of make the whole thing go. And I put a globe in there in the middle because the way we actually ran these pods and the way we frequently do it is we have one onshore, stateside, and then we have a shadow team in India. And we do this round-the-clock thing, and it just works so beautifully. Like, we have a team call at night, and we wake up in the morning, and literally it's magic. It's there, and we can just iterate so quickly. So this CODEX product, I mean, I think we did a prototype, a rapid prototyping exercise, and then we did the proof of concept. I mean, it was in 6 weeks, and we probably could have shortened that. We just had some, typical data, waiting for data from the source system kind of thing. So that's just one example of that.